Thank you very much, Dr. Abu Haniqa, for an excellent overview of the treatment in UAE and in your center. So our next speaker is Dr. Amar Lal, who is a also a friend and colleague in UAE. He's a consultant hematologist at Tawam Hospital, and he is one of the most active hematologists. He always has bunch of interesting cases in any specialty, in any disease in hematology you want. So whenever I have we want to do case presentation, I always write to him and say, do you have any interesting cases? And he has a list of them. So Dr. Amar Lal is going to present cases in relapse refractory diffuse large B-cell lymphoma.
Thank you very much. And Dr. Asma, you are always kind to tolerate me, to bring me. So good evening, ladies and gentlemen. Whatever Dr. Abu Haniqa has presented, actually, we are doing same thing. I think we're same, even Dr. Asma would agree also, they are doing same thing. Only thing is, autologous is now available in Yesh Clinic. This is the only thing additional. So anyway, so let's see, what we do in our cases. As the topic was, today and tomorrow. I made some different before, now, and later, what we do, in the case wise. So in next 20 minutes, I present few, series of cases, 4 to 5 cases, 5 minutes each cases. So as, different forum is here. So how the clinical problems we face, how the diagnostic problem we face, and when the disease relapse, then how the problems happens. So this is 50-year female who had history of B symptom. And the important thing is she came with the CBC pancytopenia, and this patient was referred from in Alain from private hospital as aplastic anemia. So here you can see the curve in 2018 when she came to us. Low hemoglobin and low platelets, 4,000 platelets, the hemoglobin was 6. The only thing is the LDH and ferritin was high. So when these things can happen, so what we do, pancytopenia, we have to review the film, hemolytic workup, and bone marrow. These are the key elements which we do. So in this patient, actually, that was done in 2019. All imaging, just, X-ray, ultrasound was normal, and films revealed nothing, any abnormal cells. Screening tests were done outside from where she came. All the things were normal. Bone marrow we did, actually, that was surprisingly normal. So this is, sometimes pathological issues. So now, after this, second question is now 50-year lady with pancytopenia, then what we should do next? Next, should we do, further digging, more scan and PET scan, what's going on with her? So we did PET scan, CT scan, that revealed actually hepatosplenomegaly, some bony lytic lesion, and we found there is something lesion in the breast as well, left breast mass. So we thought, maybe something, lymphoma or something, sitting over there in the breast, or maybe, some myeloma is there. So we were confused. So anyway, we did myeloma workup and also mammogram. So what we found, myeloma workup is so far negative, but mammogram revealed multiple bilateral masses there. So again, no meet, no treat, biopsy was done, and that revealed actually fibroadenoma. So we are again stage 0. We don't know anything what's going on with this patient. Then what we do, lot of discussion. We do, MDT over tumor board. We thought, why not again repeat bone marrow? Maybe something missing, skip lesions over there. So we did, bone marrow, and eventually we reach a diagnosis, which is the today topic, diffuse large B-cell lymphoma. Now the thing is, I always make it ABC, accurate diagnosis before beginning, check, review the labs, and then consider, potential curable treatment option, especially diffuse large B-cell lymphoma. So B means before, starting treatment, check what are other labs. So again, we re-review fever, splenomegaly, cytopenia, ferritin high, triglyceride was high, fibrinogen low, this is typical HLH. So HLH is also cooking with this patient. Now, what we should do, which can do, if in 2023, again, as Dr. Abu Haniqa said, we can give aggressively Polar CHIP or, dose adjusted. So anyway, as this patient has cancer, means lymphoma, and with HLH, so the treatment is, starting the induction therapy. Patient was very sick, so we started just dexamethasone, etoposide, and she completed this one. Then what to do next? we have these, dose-restricted R-epoch. This also include, etoposide, dexamethasone. So what we did after 8 cycles of induction HLH protocol, then she completed 6 cycles of the dose-adjusted R-epoch. Then patient 6 cycles. After this, she went for, maintenance of HLH plus rituximab. So here you see the curve from 2018 till, he finished treatment almost 1 year, and she was doing well after 2 years. So what happened? Then in 2021, she came in September 20, actually, she presented with abdomen pain. She came in the ER again. She lost to follow-up 1 year, then she came in the ER. Suddenly, abdomen pain, and we found this bulky mass over there, abdomen. Otherwise, so again, a very high LDH. So what was the thing? We did confirm, and this is again diffuse large B-cell lymphoma. And naturally, this is candidate of, salvage chemotherapy followed by autologous transplant. We did. But again, as Abu Alika has mentioned, we are away from autologous transplant. Anyway, she completed treatment of RDIP and she didn't go anywhere so far till 2023. After RDIP, she's doing great. So this is, summary. I told you, how our patients suffering. Now, what we learned here that first thing is, accurate diagnosis, wide angle, not miss the diagnosis, number one. And B is before beginning treatment, review the labs as we found HLH in this patient is very important. And then consider potentially curable, especially, kill 2 birds with 1 stone, which we have mentioned, HLH plus diffuse large B-cell lymphoma. So again, rule number 3, never forget rule number, no beat, no treat. 2, this is problem with the lymphoma, biopsy, 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 biopsy. Otherwise, so if we miss it one time, they did okay, nothing. Eventually, it will come from some other hospital, then we will be in trouble. This is the problem with the lymphoma. So this is lesson learning here. Now, this raised some question in this, when you have these type of lymphoma, diffuse large B-cell lymphoma, which is aggressive HLH plus, then what we should do? Should we go dose-resisted R-epoch or something, polar-based chemotherapy? And again, CNS prophylaxis is question mark. Should we give IgER, high-dose methotrexate and all these things? Now, if you go, this problem is solved bit in answer in 2023. Now they have put here preferred regimen, R-CHOP, and Pola-CHIP also mentioned IPI score when more than 2. This is actually in category 1. They put it over there. So it means you can use now these things if you have here. And then again in 2023, they put, which patient should be given IT. They have put some other additional as well. The patient having, high grade like MYC and BCL2 positive, and primary cutaneous T-cell lymphoma, leg type, and all these things in breast and testicular and kidney adrenal involvement, you have to give IT chemotherapy. Now, what we learned in 2019-20 case, now I come 2023, recent case, similar type of case, surprise. This is again young patient, 35-year, lymph nodes, B symptom, fever and splenomegaly, multiple lymph node from neck to pelvis, CBC again, progressive anemia and thrombocytopenia, marrow revealed extensive lymphoma involvement, and also scattered macrophage question mark of HLH cell as well over there. So node biopsy was also confirmed, diffuse large B-cell lymphoma. So now we have, advanced type. So in this patient in 2023, we give, from the beginning, Pola-R-CHIP, and now he has completed, now he's in complete remission. Just recently he finished 6 cycles chemotherapy. Now, this is how, as I'm saying you, we are learning like one case started from 2019 till 2023. This is again, 53-year female, 2019 diagnosed follicular non-Hodgkin lymphoma grade 3A stage 1 or 3B night suites, and it was diagnosed actually in Sacher Hospital. Then eventually, she came here, then she traveled to Germany, and there it was diagnosed. The patient has also diffuse large B-cell element as well. So that's why she was given actually R-CHOP chemotherapy. But after 3 cycles, they found the patient has hepatitis C as well, and patient deteriorated, decompensated, hepatitis C. As I mentioned, before beginning treatment, checked, other lab as well. In this case, you can see there is a learning. It was not checked. Eventually they found. Anyway, she completed 5 cycles, very difficulty. Eventually she came back here. She was just following to us. So this was started 2019 and 20. Then she was well, every 6 months we used to do imaging and other things. She was fine. 2023, we found she has cervical lymph node and PET scan revealed very active lymph node, and biopsy was done that was compatible with the similar, which was discussed before. And now here is 2023. If the disease relapse, what are treatment option? So again, like Abu Halika, as he mentioned, patient who is going for autologous transplant, we have to give salvage chemotherapy. And if patient is not going for intention to proceed transplant, so then you have, CAR-T, Pola-based, or, TEFA and lenalidomide-based or other therapies as well. So thing is, this patient was not, patient cannot go for autologous transplant because, as I mentioned, decompensated cirrhosis. So patient falls somewhere here. So what are choices here? CAR-T cell not available, Pola-BR is available, TEFA and Lena is not available. So we choose this one in this patient. This is recently just, I started almost 2 cycles, she finished now. And, this is a whole summary of the patient. 5 cycles of R-CHOP. After 4 years, again, disease came back. Now Pola-BR and decompensated, hepatitis C as well. And this is how, third patient is going like this way. This is a journey where our patient traveled. Now, this is the more interesting patient. I would say interesting is bad to say, interesting, although for patient is very difficulties. And this is 36-year male having backache. Eventually, patient landed in the ER, severe backache, and they found in the MRI, L5 compression, neurosurgery took over, and finally neurosurgery, they did procedure lumpectomy and found in L5, the biopsy confirmed again diffuse large B-cell lymphoma. Now, it is there. We did, we further history, we dig. Actually, she has typical all the B symptoms she had over the 6 months. She was suffering, 21 kilo loss of weight in 3 months, fatigue, loss of appetite, and all the things were there. And PET scan revealed neck to pelvic significant lymphadenopathy, enlarged spleen. And so I label this patient is 4B spleen and extranodal. So it's very aggressive type of disease. And this again, it was 2020. We just give, R-CHOP chemotherapy and with every cycle followed by, IT, and then followed by radiation therapy, which was bulk over there in the back. Now what happened? This is the first PET scan, the baseline. You see all the bones are lightening, is a heavy burden of the disease. And here was also BAS over there. And this is after 6 cycles, you can see it's almost recovered completely. But what happened? He finished treatment in February 2029. After 2 months, he was found again, positive. This confirmed, you can say, early relapse or refractory disease, very difficult disease, you can say. This is the journey started in 2020. And then you see, after just only 3-month gap, LDH went up, and this makes us alarm, although patient was not symptomatic. Anyway, we did the workup, PET scan and MRI, there was disease over there. Then what we should do in this patient? Naturally, as I mentioned before, patient is young, so patient can go for a transplant. Patient is actually Indian, so he thought he may go. So in those days, we don't have Yash Clinic, now we have. So anyway, we started now keeping this mind, the intention to proceed to transplant, not intention to not going transplant. So we started RDEP. RDEP 4 cycle finish, second, but again, after 2 cycle, complete response. As we finish 4 cycle, again, disease came back. So it's very, within 2 months, again. Then what we can do, Pola-BR. Because now we thought it's critical, patient will go anywhere. Pola-BR, after 3rd cycle, just after 3rd cycle, again, disease went up. Again, so what was left? So we were just doing experiment, which is available, or GEMOX and plus Pola. We gave, again, after 4th cycle, it didn't work as well, and disease progress. Now you see, 1st line, 2nd line, 3rd line, 4th line, 35-year young man. Now what happened? After 4th line, left paravertebral mass, you see here, increase this metabolic activity up to 15.6, very active lesions, and bulk as well. bulk and active lesion, and there is new lesions as well found. It means whatever we given, it was not working. It is truly very refractory disease. Not for what we should do. Again, going back to NCCN, second line therapy, we have to found from here something. We found here something, this is done, this is not possible. And now what we have left here, this is only left, R square, lenalidomide, rituximab. This is the only thing we left. We don't, otherwise you can see, we'll discuss later this one, third line therapy, CAR-T, biphasic, and these things which are not available. So anyway, we started in this patient. And this is how, R square means, Revlimid, rituximab. So here, week 1, week 2, week 3, week 4, he finished first cycle, then started cycle 2 to 5. Now he completed recently, I saw 2 days before actually, he has completed 4th cycle. Now I saw his 1st of June 2023 patient attended, received rituximab plus lenalidomide 4th cycle. I requested for PET scan. Patient is quite normal now. I wish it will work. I don't work or not work. So you see the 5th line of treatment which is available. We just continue, to patient comfort. Now, this patient, 34-year male, diagnosed in 2016, diffuse large B-cell lymphoma, stage 2. It was not treated here. He went in Singapore actually. Double expressor. He took R-CHOP and IT chemotherapies. He was doing well. Now after 16 means 22, means almost 5 years. He presented in the ER, dizzy and loss of balance. MRI revealed the brain in the lesion in the brain. Now we said we should do biopsy or LP. He didn't allow us. He just went back to Singapore because he treated over there. So he believed over there. So he went there, and when he came back, we found they confirmed non-Hodgkin lymphoma, and he was treated with a 5 cycle of de-Angeles protocol and followed by radiotherapy. And subsequently, he was given also ibrutinib as well as a maintenance therapy, because we don't know when the disease, it's not primary CNS lymphoma, it is secondary CNS. So when patient came here, we found disease progress actually. Then patient subsequently MRI show further progress after 2 months. Then what is the protocol? This is protocol sometimes we use. Patient started a TDR therapy. What is the TDR? TD, temozolomide, etoposide, doxil, dexamethasone, I for ibrutinib, or rituximab. This is our protocol. This is started from here D-14 till this is where is ibrutinib? Hi, this is ibrutinib. You see, this is ibrutinib. We give till here. Now patient is here. Then further, if treatment allow, we thought we'll give him, but unfortunately, patient is going sicker and sicker. He is not tolerating more, and he's now reaches, you can say, performance status 4. He's not taking treatment. This is the example, patient how diffuse large B-cell lymphoma comes, and this is only 2 minutes. I will take, again difficulties. 2020 gentleman, he was diagnosed stage 4B diffuse large B-cell lymphoma, who completed treatment. Again, after 6 months in February 2022, we found FDG activity lymph node, but he declined going for biopsy. Again, after 6 months, he came further increase. Finally, he accepted, we will go for a biopsy. We did biopsy, and our plan was to start, because the patient go for autologous, because now we have Yesh Clinic access. So we told them, we'll go for RDEP, but he didn't accept. Again, patient problem. So we give RGTP. RGTP can be given as outpatient. So he was given, and so what happened? RGTP he given, refused to be admitted because he didn't accept DAP. So after 2 cycles, patient has partial response, and patient received another 2 cycles, but again found progressive disease. So this is our progressive disease after giving chemotherapy, 4th cycle, new lymph nodes in the retroperitoneal, and the lymph nodes also in the neck as well. So what is the now option? This is what we found again in the literature, POLA-based regimen, fraction rituximab, polatuzumab, and ICE. So rituximab, POLA or ICE. This was started just recently, 18th of May. He received actually 1st cycle, day 4. So he completed 1st cycle. We'll see what will happen. So this is how, in summary of my all patients, you have seen the 2nd line therapy, patient who intent for transplant, either we give DAP or GTP, like in this patient, or RICE chemotherapy. If not going for transplant, we have available only POLA, BR. We don't have all these things. We can give gemcitabine and lenalidomide rituximab, which we give another patient. And in the future, which I told in the future, which will come like CAR T cell, bispecific, and which is, sub-Q, EPCORT map, which is also sub-Q, escalated dose, then weekly, then every monthly, which is sub-Q, and then also non-T cell therapy also.